Good afternoon and welcome to our oncology lecture series. I am Dr. Galar Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my distinct pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the pleasure of introducing Dr. Jean-Marie Stephan. His presentation is titled Updates in Gynecological Oncology. Dr. Jean-Marie Stephan is a board-certified gynecological surgeon, oncologist at Baptist Health Miami Cancer Institute. He specializes in gynecological cancer prevention, surgery, and chemotherapy. Dr. Stephan received his medical degree from the American University of Beirut in Lebanon. He completed his residency in obstetrics and gynecology at the University of Miami, part of Jackson Memorial Hospital in Florida, followed by a fellowship in gynecological oncology at the University of Iowa Hospital in clinics in Iowa City. Prior to joining Baptist Health in 2023, Dr. Stephan served as a gynecological oncologist and assistant clinical professor at Rush University Medical Center, which is located in Chicago, where he also was a lead investigator of clinical trials to help patients have access to novel therapies. Dr. Stephan's research has been published in Clinical Obstetrics and Gynecological Oncology in the American Journal of Obstetrics and Gynecology. He's a member of the Society of Gynecological Oncology, the American Society of Clinical Oncology, the American Congress of Obstetricians and Gynecological Malignancies, and the American Medical Association. Please let's give a warm welcome to Dr. Jean-Marie Stephan. Dr. Jean-Marie Stephan, what a pleasure having you and finally meet you, at least during Zoom. Thank you so much for accepting our invitation.
Hi, Dr. Hakim. Thank you so much for this warm introduction. It's a pleasure to be here and pleasure to speak today.
Thank you, sir. The floor is yours. If you may proceed to share your presentation, we can start. Perfect.
Can you guys see the screen?
Yes, we do. Thank you.
All right. Good afternoon, everybody. Again, thank you very much for having me here. As Dr. Hakim said, I'm Jean-Marie Stephan. I'm a gynecologic oncologist at Baptist, specifically at the Miami Cancer Institute here in Miami. Today, I'll be talking about some recent advances in the field of gynecologic oncology. I'm going to try to keep the presentation as simple as possible, not get into too many numbers and statistics. My goal for you is not to remember every study I mentioned, but to leave you with a sense of hope that for the first time in years, our field is starting to change and there's new promising therapies that are emerging. For the medical students in the audience, what is a gynecologic oncologist? So gynecologic oncology is a subspecialty of obstetrics and gynecology. The training requirements are, besides medical school, there's a residency in OBGYN for 4 years, then a subspecialty or a fellowship in gynecologic oncology for 3 to 4 years. That's where we learn advanced surgery, bowel surgery, urinary surgery, upper abdominal surgery, pelvic surgery. And the scope of my practice is no longer to deliver babies, but mostly to perform surgery and give chemotherapy for patients with gynecologic cancers. And we're the only oncologic specialty that does both surgery as well as chemotherapy administration. And I love that because it offers us the opportunity to have a continuity of care with the patients. As I said earlier, gynecologic oncology is a study and the treatment of cancers involving the female reproductive tract. As you can see in this graph, very simple anatomy: uterus, ovaries, fallopian tubes, cervix, vagina. We don't see the vulva here, but that's part of what we treat as well. These cancers that I mentioned account for about 11% of all new cancer diagnoses in the United States, and they also have a massive impact worldwide as well. Historically, we would operate on somebody and then give them chemotherapy, which is what we call conventional or cytotoxic chemotherapy, and then observe them until they either are cured or recurred. And most notoriously, we use two drugs called carboplatin and Taxol. These have been the backbone of treatment in gyn cancer. And there's a running joke in medical school that if a gynecologist asks you, what do you treat this patient with? 99% of the time it's carboplatin and Taxol. So this is how bad we have been doing with new therapies. However, the outcomes eventually stop improving, and it's known that most cancers eventually develop resistant to cytotoxic chemotherapy, and novel strategies were needed. I will focus in this talk on the three most common gynecologic cancers: ovarian, endometrial, and cervical. And specifically in those, there's been recent advances that have significantly improved survival rate and quality of life for the patients. And we will talk both about surgical and medical updates. Starting with cervical cancer, like I said, it's a cancer of mostly underdeveloped or developing countries. And globally, there's around 600,000 new cancers, cervical cancer per year, with around 250,000 deaths annually. And it disproportionately affects Latinas and African American women, with worse outcomes even in this patient population. It is well known that the most important risk factor for cervical cancer is HPV infection, or human papillomavirus. So a few take-home points about HPV infection. So this is a very common infection. It's estimated that up to 80% of adults, so 8 out of 10, will acquire HPV if they've had any type of sexual encounter before the age of 50. Usually, if you're immunocompetent and young, you can clear HPV. However, if there's issues with the immune system, then you will not. And there's different types of HPVs. The high risk or low risk. High risk are associated with cervical cancer. Low risks are not. So what are some updates in cervical cancer? Like I mentioned earlier, cervical cancer has a tremendous global impact. About 600,000 cases per year, 300,000 deaths per year. And it's a little bit of a special cancer as far as we're concerned, because it's widely accepted that the primary means to improve cervical cancer outcomes is not new therapies, but it's to prevent the diagnosis itself. And we already have two mechanisms that exist for that. The first is screening, and we know, that this means pap smears, and the second is HPV vaccinations. And pap smears are, widely available, whether it's self-testing or whether it's liquid pap smear or conventional pap smear. However, what are ways to improve on this screening? So more recently, there's been nanofibers manufacturers. So researchers have developed innovative approaches using engineered viral nanofibers, which specifically recognize key proteins in cervical cancer. And these key proteins, you're going to hear me mention them very much. They're called vascular endothelial growth factors, so VEGF, and programmed death ligand 1, PDL1. So I'll refer to them going forward by VEGF and PDL1. So the dual display nanofiber shows in studies significantly improved detection and sensitivity compared to conventional pap smears. In addition, knowing that somebody has HPV is no longer enough. We need ways to quantify HPV, and quantification of HPV is directly proportional to prognosis and the ability to create pre-cancer and cancer. So now there's high throughput sequencing for HPV detection, technology which enhances the understanding, the detection, the risk evaluation, and is transforming cancer research. Lastly, AI is taking over the world. So now we have machine learned based systems. So AI, these computer-aided systems analyze cervical cancer images and assist clinicians in deciding whether this is something concerning, identifying cancer or pre-cancer, so basically in risk assessment. That's the screening part. As far as HPV vaccination exists, so the HPV vaccine has been approved all over the world. In the United States, starting age 9 for men and for girls and boys. And in countries that have introduced HPV vaccinations with significant uptake, for example, like Australia, we've seen substantial reduction in HPV infection and precancerous lesions and subsequently cancer. We have 4 different types of vaccine here that are approved. However, despite all research pointing and evidence pointing to the fact that HPV vaccination works, we have less than 50% of girls or women in the United States vaccinated and less than 30% of men or boys vaccinated. So we can talk about strategy for therapies and new chemotherapy and immunotherapy. However, we need to do better as a population, as healthcare providers, to vaccinate at a much, much higher rate than that. That's where most of the improvement in cervical cancer can come in the future. Now, with that being said, what are some of the new therapies or new promising emerging therapies in cervical cancer? So you're going to hear me talk in this talk about biomarkers. So biomarkers are things you can measure, whether it's in the blood or molecularly, and things that are not everybody has. So two people with cervical cancer can have different biomarkers. So somebody could have one, the other could have a different one. And that's why one person will respond to this therapy and the other will not. But the key is, how do we determine which biomarkers this patient had, and how do we personalized treatment towards them? So, and specifically in cervical cancer, I mentioned earlier, VEGF and PD-L1 are key targets in cervical cancer therapy. They're valuable biomarkers in predicting treatment response and prognosis. And these two biomarkers have opened the door to both anti-angiogenic therapy. So instead of regular chemotherapy that kills cancer, now we're giving chemotherapy that stops cancer from feeding. So we're blocking blood supply, stopping cancer from feeding, and therefore cancer starves. This is called Avastin. That's the name of this drug. It also opened the door to immunotherapy that targets PD-L1. So you're going to hear me talk about pembrolizumab, and you don't need to remember any of these names. I just want to give you an idea about how, all the new therapies coming. So pembrolizumab is now approved in cervical cancer treatment. That's an immunotherapy. So to give you a little bit of a timeline, so 2009 was the first time pembrolizumab was approved initially, and that's because it showed an overall response rate, meaning you give it to 100 patients, 15 of them respond. It sounds low, but before that, the numbers were 5%. But on top of that, it's the duration of the response lasts longer and the side effects are less. So in 2009, the FDA granted approval for Keytruda alone in treatment for recurrent cervical cancer. 2021, another big study. Again, this time in frontline setting. So how about, why wait for the cancer to come back? Can we use Keytruda in the beginning? So again, we combined Keytruda with chemotherapy. We combined it with Avastin, which is the anti-angiogenic drug I mentioned earlier, and found better progression-free survival. The patient stayed without cancer longer, and also better overall survival, so lived longer. So Keytruda was approved in 2021. And just recently, in 2024, early stage cervical cancer is treated with something we call chemoradiation. So we give a small dose of cisplatin, which is a chemo, and then give 5 days of radiation. We do that for 5 weeks. So we were looking into whether Keytruda could be used along with cisplatin. And again, that study showed better progression-free survival, better overall survival, and more recently, the FDA approved Keytruda in that setting. So pretty recent, 2019, 2021, 2094, 24, immunotherapy is taking over the cervical cancer world. Now, another thing you're going to hear me mention is something called an antibody-drug conjugate. I might say ADC sometimes. So the antibody-drug conjugate is a complex system, but just to explain it, in a simple way, it's when we give chemotherapy, a lot of the time it doesn't discriminate. So there's a lot of side effects associated with it because it targets cancer cells, but it also targets healthy tissue. So these antibody drug conjugates, they go, and because, kind of like a key and lock mechanism, they bind to cancer cells and they get absorbed in it. So they're carrying poison inside of them. So they get absorbed into the cancer cell and they kill this specific cancer cell, limiting the damage to cells next to it. So it's a directed therapy with less side effect. So I will mention in this case something called tisotumab vedotin, which also which we refer to as TIVDEC. So in 2021, this is the first ADC that was approved in any gynecologic cancer. And this was based on a study in a specific population of cervical cancer where we had responses of less than 5% with the best therapy available. This one showed response rate of 24, 25%, so 1 out of 4, as well as better progression-free survival and overall survival. Then we decided to use other disease sites that have done a lot more research than us. So breast cancer uses trastuzumab, which a lot of you might recognize, Herceptin. And this is kind of a cousin of it that also gained approval for cervical cancer, specifically ones that have the biomarker called HER2. So now we don't treat every cervical cancer the same. We look for biomarkers, PD-L1, we look for HER2, we look for VEGF, and we target cervical cancer differently. Just for you to see how, to have an idea how busy this timeline is. So this is just over the past 4 years, the studies that are either done or ongoing or currently still going, 2001, 2022, 2023, 2024, all of them looking at immunotherapy and ADCs in cervical cancer. So a lot of exciting things in the pipeline. Now, what is new in terms of cancer surgery in cervical cancer? So historically, cervical cancer has been treated with something we call radical hysterectomy and lymph node dissection. So hysterectomy meaning removing the uterus. Radical, if you look at the images above, the two wings that you see on the side, those wouldn't be there if we're doing a simple hysterectomy for non-cancer. So just removing that small tissue on the side, the little wings, makes this a radical surgery. And even though this looks small, it increases the complexity of the surgery a lot, as well as the potential complications from surgery. So some people started looking at, well, does everybody with cervical cancer need a radical hysterectomy? And does everybody need a full lymph node dissection? And there's been a slow shift towards less invasive surgical options. So 2 trials were made, one called the Conserve that you see here, and the other one called the Shape. And I won't get into too much the details, but both of them looked at whether a simple hysterectomy or even a cone, so just a large biopsy of the cervix to preserve fertility, was worse in a select group of cervical patients. And most recently, 2023, the Shape trial was published, showing no inferiority, meaning the recurrence rate, whether you do a radical hysterectomy or a simple hysterectomy or a cold knife cone biopsy, for a selected group of early stage, low risk cervical cancer is the same. It's 3%. So more and more, we're moving towards less surgery, or actually selecting the people we could do less surgery for. That applies as well to the sentinel lymph node dissection. So instead of removing all the lymph nodes next to the cervix, causing possibly lymphedema in patients, or running in trouble in surgery by causing, massive blood loss or nerve damage, we again relied on our colleagues from the breast cancer world, so where sentinel lymph node is now the standard of care. And sentinel lymph node means removing the first lymph node that drains a specific organ. And I'll talk more about the technique when we get to endometrial cancer, but this is more and more becoming also the standard of care in cervical cancer. There's been trials done, one of them called Sentinel trial, that showed very high sensitivity, very high negative predictive value, and we're more and more moving towards that. One thing I will mention here that is, that is different than other cancers, other gynecologic cancers, is minimally invasive surgery versus open surgery. So minimally invasive surgery includes laparoscopy and robotic surgery. And since 2004-5, when the robot was introduced, all fields of surgery in general have moved towards minimally invasive. It isn't until 2018 when we decided to actually do a trial and look, well, do patients that get minimally invasive, whether it's laparoscopic or robotic radical hysterectomies, do they do as well as patients who do open radical hysterectomies? And the results were very, shocking to everybody in the gynecology world. Open radical hysterectomy versus MIS. MIS showed worse outcomes in terms of recurrence, in terms of survival. So this was challenged initially. However, it has been reproduced multiple times globally. And now the standard of care for cervical cancer radical hysterectomy is to do it open, which is very, very different than our other cancers and all cancers basically across, multiple other solid organs. So we're seeing in cervical cancer a shift towards less invasive surgical options, as evidenced by the SHAPE trial that I mentioned, which is a significant evolution in the management of low-risk early-stage cervical cancer. It's a movement towards treatment strategies that balance efficacy with patient well-being, prioritizing not just survival and cancer outcomes, but also overall quality of life in the patients. These insights paved the way for new standards in gynecologic oncology, where the choice of the surgical method can be tailored more precisely. And this is the word here, tailored. We're treating people differently based on certain biomarkers or certain pathologic criteria that we find. And we're altering the traditional approach to surgical management in cervical cancer. Moving on from that to endometrial cancer. That's the most common gynecologic malignancy in the United States. That's also the only gynecologic malignancy that is increasing in incidence despite all advances in technology. Every other cancer is decreasing in incidence because we're doing better at treating it or preventing it or catching it early. Endometrial cancer is the only cancer where the incidence is increasing, and that is most likely related directly to the obesity epidemic, given that endometrial cancer is a hormonally produced cancer, mainly estrogen. What are some updates or advances in the therapy when endometrial cancer is concerned? So again, we're going to talk here about biomarkers and immunotherapy. Thankfully, a lot of it is the same, so you won't hear a lot of new words. The biomarkers in endometrial cancer are either PD-L1, which we mentioned, or something we call MSI, so microsatellite instability, or dMMR, mismatch repair protein. So this is basically an indication of the ability of a tumor cell to repair itself. So do they have the ability or do they not have the ability? And we can, those biomarkers are used because if a cell doesn't have the ability to repair itself as well, then if we promote the immune system to fight it, it can't resist. So in that respect, we also are seeing an era of immunotherapy in endometrial cancer. Traditionally, it's always been carboplatin and Taxol, similar to before. However, again, in 2019, a study looked at recurrent endometrial cancer with Keytruda. And this Keytruda that had the biomarkers. So, endometrial cancer that had the biomarkers, MSI or dMMR. And we found a much improved progression-free survival, much improved overall response rate. Next, moved in 2021 to look at Keytruda along with another drug that also works on the immune system called Lenvima. So these drugs were given together for recurrent or advanced endometrial cancer and compared to conventional chemotherapy, found to have better overall survival, better progression-free survival as well. A couple years after that, 2023, both Keytruda and another drug that is similar, so pembrolizumab as well as dostarlimab. So these two drugs, there's been two major trials published that same year, very similarly made, that led to the approval of both these drugs in the frontline setting. So we're no longer just giving carboplatin and Taxol for endometrial cancer. Now we give carboplatin and Taxol with Keytruda or with dostarlimab, and then we continue Keytruda and dostarlimab alone for a period of 2 years. We call that maintenance therapy because they don't have a lot of side effects and patient can tolerate them. And we found an improvement in progression-free survival, an improvement in overall survival in these patients. And this led, so these are the two trials I mentioned. So I won't get into the details here, but they're very similarly made. One looked at Pembro, the other one looked at Dosta. Similar results, similar side effects, just a few differences in eligibility criteria. You can see here the graphs very clearly. The Pembro and then the dostarlimab group are separating, showing improvement in PFS that is maintained over time. This led the FDA to approve dostarlimab in endometrial cancer that has the biomarker. And just I added this slide for you to know that this is pretty recent. I mean, this is July of last year. So those are all things that are relatively new in our world. Again, this was added in the NCCN guidelines. I circled the areas where it says that we could use pembrolizumab or dostarlimab and in which conditions and which patients. So it's pretty much standard of care at this point. When I was talking about cervical cancer, I mentioned sentinel lymph node dissection, and I said I'll talk about it more when we get to endometrial cancer. So a sentinel lymph node dissection is removing all lymph nodes next to an organ within certain anatomical barriers. However, it's a technique that can cause lymphedema, that costs time, that can result in bleeding, patient morbidity. So in a way to avoid that, we're looking at sentinel lymph node dissection. If we remove the first two lymph nodes on either side of the uterus, for example, that drain this area, are we getting an adequate representation of all the lymph nodes in that area? So the fear was, well, we can find the sentinel lymph node, but are we missing other lymph nodes that are positive? Because if we are, then we're reassured that the patient is in early stage, for example, and we don't treat them. And we've actually missed a patient that is in advanced stage and should have been treated. So it's very important for sentinel lymph node to be sensitive and to have a high negative predictive value. So the way we do sentinel lymph dissection is we inject this powder that we turn into a liquid called indocyanide green. So it's a green liquid. We inject it in the cervix, as you can see in the picture here, one of the three diagrams. And then using radio frequency technology, we're able to actually see the green light up, and we're able to see the lymphatic channels, and we're able to follow them from the organ to the lymph node. So most of the time, we can find these sentinel lymph nodes and remove them. If this is the algorithm in case we don't find them. So if we don't find a sentinel lymph node, we're still required to do a full lymphadenectomy on that side. So, but what studies did we use? How do we know that it's safe to do sentinel lymph node dissection? How has it become standard of care? So three main studies. One called the FIRES that looked at early stage endometrial cancer, but mostly low grade. So cancer that doesn't really metastasize to the lymph nodes. And we find high sensitivity and very low false negative rate. Now, how about high grade endometrial cancer, serous endometrial cancer, cancer that is, has more likelihood of metastasizing to the lymph node? Are we sure it's safe there? So two other studies done, high sensitivity and low false negative rate. So this has led us to now consider sentinel lymph node dissection the standard of care in endometrial cancer. Moving on to ovarian cancer, which is our most lethal cancer. It's also the second most common gynecologic malignancy in the US. Well, this is a pretty dark slide showing how little improvement we made from the 1960s all the way to mid-2010. So for the entire 50 years, all we did was use and recycle cytotoxic chemotherapy. And it isn't until the mid-2010 that field started exploding. And it started exploding mainly with Avastin that I mentioned earlier, which is an anti-VEGF monoclonal antibody, but more importantly, with what we call PARP inhibitors. And I'll talk about those in a second. These drugs have pretty much, caused a lot of excitement in the field when it comes to ovarian cancer. So how do we treat ovarian cancer? So ovarian cancer usually requires surgery followed by chemotherapy. So you can see here, on the left, we either start with surgery, then we do 6 cycles of course, carboplatin and Taxol. This is traditionally. Then we watch these patients until they recur. And unfortunately, more than half of them recur. So it's not a very good strategy to try and cure this cancer. On the right side, you can see that we can sometimes start with chemotherapy, then do an interval surgery, then finish the chemotherapy. Why do we do one over the other? Because in ovarian cancer, surgery is probably the most important part of the treatment. And the most important part in surgery is to remove all the cancer. So if we don't think we can remove all the cancer up front, then we give chemotherapy to shrink the tumor, then we do the surgery, then we finish the chemotherapy. But recurrence rate is very high. It was clear that we needed something new. So in around 2014 or 2018, actually, PARP inhibitors came to be. So what are PARP inhibitors? So these are drugs that target DNA repair pathways in cancer cells, leading to cell death in tumor, mostly in tumor, again, that lack the ability to repair themselves well. And these are BRCA mutated, so those are the hereditary ovarian cancer, or what we call HRD, homologous recombination deficient tumors. So again, these in ovarian cancer, those are our biomarkers, BRCA and HRD. And the three most common drugs, and there's many others that are PARP inhibitors, but these are the initial ones, are olaparib, niraparib, and rucaparib. So the incorporation of these PARP inhibitors as maintenance therapy mainly. So following carboplatin and Taxol, we give these drugs because they're well tolerated, they're oral, so they're by mouth, and people can stay on them up to 2 years with relatively, well tolerated side effects. So the incorporation of these PARP inhibitors as maintenance therapy in ovarian cancer has been one of the most important breakthrough in gyn-oncology. There's been unprecedented results with up to 70% improvement in progression-free survival in the well-selected patients. These drugs have been approved by the FDA for multiple indications, some of them similar, some of them different, depending on presence or absence of biomarkers. So I won't get into the indications very well. These are easily available online. But it's interesting to know that prior to that, we had nothing. And with that, overall progression-free survival improved, as well as overall response rate. So we can see in a slide after that, these are all ongoing trials about ovarian cancer with different types of drugs that are not cytotoxic chemotherapy. You can see, I mean, there's so many things down the pipeline, all of them either currently ongoing or we just have the results, but we're still waiting on the papers to be published. Very exciting time for ovarian cancer. Bevacizumab, which is Avastin, is a little bit older now in ovarian cancer, so I won't get into it. Immunotherapy is mostly in trials, although Keytruda has been approved in recurrent ovarian cancer that is PD-L1 positive. Again, I come back to biomarkers. So not everybody will benefit from it. It's patients who have the biomarker for it. We go also back to ADC. So I will mention that because in ovarian cancer, we have patients that respond to chemotherapy, and we have patients that we call platinum resistant. So the platinum resistant patients are the patients that do the worst. These are patients that unfortunately live, less than a year. And despite all the chemotherapy we had, these patients do not respond. So MIRV, which is a short name for mirvetuximab, is an ADC that targets folate receptor alpha. So in this case, folate receptor alpha is the biomarker. And there's been two big studies, one called the Soraya study, one called the Mirasol study, that looked at the efficacy of MIRV in folate receptor alpha positive platinum resistant ovarian cancer, showed improved in PFS, progression-free survival, as well as improvement in overall response rate, as well as, very importantly, improvement in overall survival. Patient lived longer. And it didn't matter whether these patients had been heavily treated before or not. So again, very new. The improvements are modest, but it's more than what we had before. As far as advances in surgery in ovarian cancer, I mentioned earlier, surgery is extremely important in ovarian cancer. However, if we give neoadjuvant chemotherapy and we do interval debulking surgery, we now have a way to improve outcome in these patients. So we looked at something called HIPEC. HIPEC is hyperthermic intraperitoneal chemotherapy. That's something that's not new. It's something that's been used for years and years. However, we never had data showing that it works or in what situation it works. And it was never standard of care in our cancers. It's used very widely in the colorectal world. So specifically HIPEC, and I'm going to show you how it's given. So once we finish surgery, there's a machine next to the patient that heats the chemotherapy. There's an inflow that puts chemotherapy inside the patient so that it's touching the organ, touching whatever cancer is left. And there's an outflow that heats it again, and it keeps coming back. We do that for 90 minutes, one time only during the surgery. This is a picture of one of our, HIPEC setup. So you can see the skin is closed and there's an outflow, inflow. Why is HIPEC good and what are the advantages? Well, basically, it increases penetration of chemotherapy because it's touching the surfaces. It increases concentration of chemotherapy. It increases the sensitivity of the cancer to the chemo. And we have to remember that a lot of the areas where there's cancer, there's necrosis, so not good blood supply. So if we give chemotherapy in the IV, it might not reach those areas. So now we're touching them directly. And how do we know it works? Well, there's a study that was published in 2018, again, in the New England Journal of Medicine, comparing interval debulking surgery with or without HIPEC. And following these patients, there was an improvement in median overall survival, about 12 or 13 months. The patient lived a year longer with similar adverse effects. So as of now, HIPEC, again, is a standard of care in patients who need interval debulking surgery for ovarian cancer. Is there any surgery advances that apply to all? Well, yes. very important, we know our patients are all women. Some of them are young and desire to preserve fertility. So a lot of our treatment, whether it's chemotherapy or radiation to the pelvis, doesn't allow that. So in the past, there's oocyte preservation, ovarian tissue freezing. All of these are things that, are not new. However, the procedures to preserve fertility, some of them are new. So in the past, we would transpose ovaries, meaning we would bring ovaries out of the pelvis and then put them somewhere in the upper abdomen and allow the patient to get radiation to the pelvis. That will kill the uterus. However, the patient will still have her ovaries, so she would not go into menopause, and then she still has eggs in case she wants to find a surrogate and have, biological children. However, there are patients who want the ability to keep their fertility for spontaneous pregnancies, carry their own babies, and deliver their own babies. And for those patients, there's a new technique that we proudly offer here at Baptist, and that is not very common. So this technique is called uterine transposition. So instead of removing the ovaries only from the pelvis, we now disconnect the whole uterus along with the ovaries, preserving the blood supply, and move the uterus up to the umbilicus or to the upper abdomen, allowing the patient to receive radiation. And we'll come back following radiation and reconnect the uterus to the vagina, a healthy uterus, healthy ovaries, allowing the patient to carry her own pregnancy. So this is not very common. This is only done in 2 centers in the United States. It's been done in Latin America, specifically in Brazil mostly, but this in the United States, only 2 centers, one in New York, and then the second center was us here in Florida. And this was done a couple months ago here. This is a picture of the actual patient I operated on where we did that first surgery. It's an MRI showing in the middle, that's the uterus that you see in the middle. It is at the level of the umbilicus. It is connected through the umbilicus, kind of like a colostomy, allowing this patient to menstruate while she's receiving treatment through her umbilicus. And she's going to finish treatment, this patient specifically, in the next couple months, where we are planning to go back and reconnect this uterus down to the vagina. This was all done minimally invasively with 4 incisions. So I will update you once we have the final result, and hopefully she gets pregnant. Last slide here. So emerging technologies, I will go very quickly here. Liquid biopsy, there's talk of early detection and monitoring of cancer through blood tests. Again, this is experimental. AI will definitely have a big role to play in diagnosis, treatment planning, predicting outcome, improving accuracy and efficiency of detection and testing. We need novel targets. We need personalized medicine. That's where this field is going. So we need to continue developing individualized treatment approaches, integrating genetic and molecular data to tailor therapies to each patient's unique profile. And once we do that, it's important to remember not every cancer is the same. Even if you have the same type of cancer, it could be treated and respond very, very differently. And that's what we need to dig into. And that's it. Thank you very much for listening and letting me speak today.
Dr. Stephan, I am in awe with the amount of incredible advancements in GYN oncology. And I know our peers feel the same way. We are so privileged to have you in our team in the midst of these advancements. It is absolutely remarkable when we heard about the uterine transposition that you and the team performed, being one of 2 facilities in the nation that actually has done this. You left us all salivating at this point. I'm sorry to be so brutally honest, but from the scientific standpoint, this is a miraculous type of procedure, if you were to actually ask us, simply because you are allowing that woman to be at least in the hopes of conceiving in the future while receiving a major treatment for cancer. So all encompasses this incredible amount of information that it is perhaps at the verge of being the standard, hopefully universally, to help women. But the alarming numbers still out there. 11% of cancer diagnosis in the US is related to GYN type cancers. And then you mentioned something that hit me. 6,000 women are diagnosed with these variation of these cancers, either cervical or whatever, and 250,000 deaths. That is an incredibly alarming still type of cancers that we all need to be cognizant of. Obviously, we always talk about heart disease and breast cancer and prostate in men. But the fact of the matter is that now, with the advent of the new technology, the provision of vaccines like HPV in children, we still have so much to do in the prevention standpoint that perhaps you guys will have a little bit of a breathing room. However, the amount of medications that now there are in your armamentarium are just mind-boggling. And I love how you framed it for us because obviously I'm from the old school, and yes, there were two medications. This is the way we're going to do it. End of story, and let's pray and hope for the best. But now these combinations of immunotherapies, it is absolutely astonishing. And it's always in my mind, how do you guys select the appropriate combination of immunotherapy? That is perhaps one of the biggest conundrums for guys like me that are not OBGYNs or oncologists. So how do you do that? Can you just bring it down to us?
Right. There's at times it's impossible to do. At times it becomes a matter of what you're comfortable with, what you've used more. But at other times, it depends on the patient. So although they're both, they're all immunotherapy, they have different side effect profiles. So if a patient is suffering from, you know, whatever side effect, and this drug causes that, then you don't choose that drug, you go to the other. Also, we tend to abide by the eligibility criteria of the trials. So all these trials have very strict eligibility criteria. And although I said that they're very similarly constructed, some of them are a little bit different. There's some things that are different. So we tend to look at the patient's characteristic, the pathology characteristic, and then go with the drug that fits what that patient is. But the truth of the matter is that they're very similar in side effect profiles, very similar in outcomes. And a lot of it comes down to if a patient can take both, you give the one that you're used to doing.
Mm. And in the case of a combination of cancers, for instance, in the case of that a mastologist comes to you and says, you know what, now we have a type of cancer that can be originating from hormonal type systems like ovaries. Are there any thoughts in regards to this type of invasive type of treatment in which now you need to remove ovaries in order for you to continue treatment for breast cancer? Are there any talks about that?
Well, we unfortunately have to do that a lot for young women. So that takes me back to the fertility preserving options where we can, a lot of these women, when they come to us, like, let's say estrogen uh, receptor positive breast cancer in a young woman, premenopausal, finished her treatment, needs to be on hormones. So a lot of time they need to shut down her ovaries for her to get the better hormonal treatment. And they send them to us to remove the ovaries. So before they do that, we make sure they see an infertility specialist, a reproductive infertility specialist, where they can have, egg harvesting, and go through any of the options of fertility preservation. But unfortunately, outcomes in those specific patients, according to our oncology colleagues who treat breast cancer, improve a lot if we do remove the ovaries and make them menopausal, so they can get a different kind of hormonal treatment than the regular tamoxifen.
Dr. Stephan, Stephan, that's actually one major concern of young patients that are recently being diagnosed with breast cancer. And we obviously refer to your team for support, obviously, once the surgeon determines that. How long does the process take between you determining, yes, I need to remove the ovaries, and this is perhaps some of the options you have, but you need to start your treatment as soon as possible? What is that time frame in your mind should be or looks like?
Most of these patients, when they get to us, when we see them as gynecologic oncologists, we see them for surgery, not for the decision has been made with the oncologist that's been treating their breast cancer. They send them to us for surgery. However, they're on treatment at that time. They're just getting a quote unquote less good treatment that they could than if their ovaries were out. So it's not like they're waiting to be treated. These patients are being treated. We might suspend treatment for a period of 14 days, and that's how long it takes to do the fertility preservation and the embryo retrievals. So for those 14 days, they go off treatment and they go on hormonal treatment with an infertility specialist.
I see.
But overall, they're being treated throughout that whole process.
So from beginning to end, once we determine, then the next step is obviously once it comes to you, it's because they're going to proceed with
Correct.
surgery.
Correct.
Everything else has been taken into account.
Correct.
Good to know. Now, you did mention something awfully important that a technology that you've been used for quite some time, which is HIPEC. And not necessarily every patient is a candidate for it, but it is somewhat a tempting question to ask, why don't we actually, if we are going to submit a person to a surgery, why not offer HIPEC? And perhaps it's a combination of medication, perhaps is the actual viability of that medication at the moment. But what is the limiting factor for you to actually use HIPEC for a candidate?
Correct. So none. Anybody that is a candidate should receive HIPEC. And we kind of go based on evidence, right? So there's been a lot of trials looking at HIPEC and the correct timing of HIPEC. And most of them have been controversial. So good results here, bad results there. However, the trials that looked at HIPEC at this interval time of surgery. So somebody that got chemotherapy in the beginning rather than getting immediate surgery, followed by surgery. Those patients, when they receive HIPEC, we found better outcomes compared to that if they don't. So that's become standard of care in that setting. In the frontline setting, it waxes and wanes. It was standard at some point. It was very used, and then it stopped being used. And there's current trials right now looking at it again. So we don't have a definite answer in the frontline setting. However, in the interval debulking setting, the gyn-onc community came to a consensus based on evidence that those patients should receive HIPEC. It is, you have to know it's time consuming. So if you end up going to, somewhere in the community or in private practice, I doubt that they have the ability, the technology, or the time to do that, which is why, again, we're happy that we provide this at Miami, at MCI and at Baptist. Other, institutions that are academic will provide that. However, a lot of the private physicians do not.
Yeah, you're adding an hour to the OR time as well.
At least an hour.
Yeah. And then you have to wait, and then the post-op. So
Right.
definitely. But I love the fact that you mentioned that it adds 13 months in an average to the life of a person, to the life of a woman. I mean, that is definitely not worth an hour. It's worth 4, in my opinion.
Absolutely.
But then again, look, these technologies, the HIPEC, the adjuvant radiotherapy, and of course the uterine transposition, these are phenomenal tools that you're using, and we commend you for everything that you're doing. We are so very proud of you and your team for helping us here at Miami Cancer Institute approach that level of excellence that we are so very well known for. So you know what? This is such an interesting topic. I could keep you for hours talking about it and learning from you, and it's a true honor having you. So I'm gonna let you go because I know that you still have patients to see, and I want to thank you on behalf of our entire team at Baptist International for accepting our invitation, Dr. Stephan, and for your informative presentation, and to all of you for participating. Thank you so much for your
Thank you,
interest.
everybody. Dr. Hakim, pleasure meeting you. Thank you, everybody, for listening.
Thank you, Doctor. Thank
Bye.
you.
Good day.
Thank you. And to all of you for participating today. If you do have any questions or any concerns, or obviously need to refer someone to Dr. Stephan, please let us know. Email us at bhiwebinars@baptisthealth.net. That is bhiwebinars@baptisthealth.net. We look forward to seeing you all in our next oncology lecture series, which is scheduled for Wednesday, October 2nd, 2024. In the meanwhile, stay cool. Thank you so much once again, and have a great afternoon. Thank you, Dr. Stephan.